Okay, so today we will discuss coronary circulation. Okay, coronary circulation and its clinical aspect, ischemic heart disease. This is very common nowadays, ischemic heart disease. Coronary circulation very important for your long question, theory question. Coronary circulation is important, or it can come as a blood supply of the heart. Okay, it consists of both the arterial supply and venous drainage. So first we will discuss the arterial supply. Heart is supplied by two coronary arteries, right and left coronary arteries. See here, this one is right coronary artery and this is left coronary artery. They are arising from the ascending aorta just above the aortic valve, okay, from the aortic sinuses. Aortic valve have three leaflets, so just above the leaflets there is some dilatation in the wall of the ascending aorta. This dilated portion is known as aortic sinus, and these arteries, right and left coronary arteries, are arising from the aortic sinuses. These are vasa vasorum. Vasa vasorum means blood vessel supplying the wall of the vessel. So these coronary arteries are supplying the wall of the heart. So these are vasa vasorum of ascending aorta. Okay. So heart is supplied by two coronary arteries, right and left. Only innermost 75 to 100 micron of endocardial zone, it receives nutrition directly from the blood, and that lies within the chambers of the heart. Only innermost layer, endocardium, is supplied by blood in the chambers of the heart, and rest of the portion is supplied by this coronary arteries, myocardium, epicardium. These are supplied by these coronary arteries. Okay, so what are the features of coronary arteries? This is also asked in your viva, important viva question. Okay, so coronary arteries arise from the ascending aorta, and also this viva asked during your heart viscera table, thoracic viscera table. Heart will be given, heart and lung. Okay, so in viscera table also you will be asked about this coronary circulation. Coronary arteries arise from ascending aorta. Coronary arteries are vasa vasorum of the aorta. The coronary arteries are functional end arteries, but not an anatomical end arteries. That means they have connections in between the branches of the arteries, but this connection does not work functionally. Okay, and they receive blood during ventricular diastole. This is also an important explain why question. Okay, coronary arteries, why coronary arteries are functional end arteries but not anatomical end arteries. In case of any blockage in this coronary artery, the distal portion will not get blood supply. It will, blood supply cannot come from the anastomotic portion from the other arteries. Okay, that's why it leads to ischemic heart disease, and they are prone for development of atherosclerosis and receive the blood during ventricular diastole. See here, this is aortic valve. You can see the three leaflets. So here is origin of right coronary artery, and this is origin of left coronary artery from the two aortic sinuses, and this is non-coronary sinus because no coronary artery is arising from this coronary side, from this aortic sinus. Okay, and this is pulmonary valve. You have seen pulmonary trunk lies in front and posterior to it lies the aorta. Now we will discuss individual coronary artery. First, the right coronary artery. Right coronary artery origin, it arises from the anterior or right aortic sinus of the ascending aorta. Aortic sinuses are dilatation of the aortic valve just above the aortic valve, and right coronary artery is smaller than the left coronary artery. See, this is one schematic diagram, cross section through the heart, aortic valve, pulmonary valve, tricuspid and mitral valve. See, this is right coronary artery and this is left coronary artery. They are anastomosing here in this plane. So what is the course of the right coronary artery? The course of the artery can be divided into two segments, first segment and second segment. Up to this inferior border, this is first segment, and on the posterior aspect, this part is the second segment. So, first segment, the right coronary artery arises from the anterior aortic sinus, passes forward and to the right between the pulmonary trunk and right auricle. Then the artery runs vertically downward in the right atrioventricular groove up to the inferior border of the heart. So, from here, from this origin up to this level, this is first segment. Next, the second segment, artery winds around the inferior heart border to enter in the right side of the posterior atrioventricular groove, and the artery ends by anastomosing with the circumflex coronary artery. Okay, this is a branch from left coronary artery. In the posterior atrioventricular groove, they are anastomosing. See here in last view, this is the right coronary artery anastomosing with this circumflex artery. Circumflex artery is branch of left coronary artery. Left coronary artery is dividing into two branches, anterior interventricular artery and circumflex artery. Next we go to the branches of right coronary artery. What are the branches? First is right conus artery. Right conus artery, also known as arteria coni arteriosi. It is the first branch of right coronary artery and it supplies the infundibulum of the right ventricle. Okay, conus artery. Here is the right conus artery. Two conus arteries are there. So, there is another conus artery from this anterior interventricular artery. They are forming a they are anastomosing with each other around the infundibulum of the right ventricle. Next is right anterior ventricular branches. These are 3 to 4 in number. These are the right anterior ventricular branches supplying the right ventricle, supply anterior surface of right ventricle. Next is right marginal artery. It is the largest ventricular branch. Here is the right marginal artery. Largest ventricular branch runs along the inferior margin of the heart towards the apex and supplies the sternocostal surface of the heart. Next is atrial branches. These are 2 to 3 in number. Here these are going towards the atrium. These are atrial branches, 2 to 3 in number, and there are anterior, lateral and posterior atrial branches and that supply the right atrium. Next we go to SA nodal artery, sinoatrial nodal artery. It supplies the SA node and in 60% individuals it arises from the right coronary artery, whereas in 40% cases arises from the left coronary artery, this SA nodal artery. There is variation. Right posterior ventricular branches, these are 2 to 3 in number, arise from the second segment of the right coronary artery, supply the inferior or diaphragmatic surface of the right ventricle. Okay. Next is posterior interventricular branch. You have seen anterior interventricular artery is branch from left coronary and posterior interventricular branch is from the right coronary artery. Okay. It arises from right coronary artery in 90% of the individual, and according to the origin of this posterior interventricular artery, there is coronary dominance. Mainly there is right coronary dominance because it 90% cases arises from the right coronary artery. Okay, and it runs in the posterior interventricular groove, and this artery ends by anastomosing with anterior interventricular artery. It gives septal branches for the posterior-inferior 1/3 of the interventricular septum, nodal branch in 60% individuals for AV node, and ventricular branches for inferior surface of right and left ventricle. So, these are the branches from posterior interventricular branch. Okay. See here, this is posterior inferior view of the heart. Here is the location of coronary sinus at the atrioventricular groove, and this is posterior interventricular groove. So, this branch is coming posterior interventricular artery branch from the right coronary artery, and in the lower part it is anastomosing with the anterior interventricular artery. Okay. The anastomosis, anterior interventricular artery pointing round near the inferior heart border, anastomosis with the posterior interventricular artery in the posterior interventricular groove. Okay, and you can see the interventricular septum, anterior 1/3 is supplied by the anterior 2/3 is supplied by the anterior interventricular artery, that is by the left coronary, and posterior 1/3 is supplied by the right coronary by the posterior interventricular artery. This is supply of the interventricular septum, and you can see the wall of the left ventricle is thicker than the wall of the right ventricle, and its cavity is rounded, and here the cavity is crescent shaped in right ventricle. So, area of distribution, right coronary artery supplies the following parts of the heart: right atrium, right ventricle except a small part adjacent to anterior interventricular groove, left ventricle adjacent to posterior interventricular groove, interventricular septum in the posterior 1/3 only, and conduction system of the heart except the left bundle branch. Okay, so these are the area of distribution of right coronary artery. Okay, so this is summarization of right coronary artery. Arise from the anterior aortic sinus of ascending aorta, runs in the right part of the AV groove. These are the branches. Okay, so if it comes as a coronary circulation, you have to write down all these things. Okay, origin, branches, supplying area, all these you have to write down. So branches are right conus artery, and you practice a schematic diagram of these two arteries, right and left coronary artery, their branches like this. So right conus artery, right anterior interventricular branches 3 to 4, right marginal artery, atrial, right anterior not interventricular, this is ventricular branches supplying the ventricular wall, right ventricle wall. Right marginal artery, atrial branches 2 to 3 in number, right posterior ventricular branches also 2 to 3 in number, and synodal artery in 60% cases, posterior interventricular artery in 90% of cases, and septal branches, AV nodal branch, ventricular branches. All these are branch from right coronary artery. Okay. This is annulus of Venous, anastomosis of conus arteries from right coronary artery and anterior descending coronary artery, that is anterior interventricular artery. This is left conus artery and this is right conus artery. They anastomose with each other to form the annulus of Venous around the infundibulum of the right ventricle. Okay. Okay, third coronary artery. If the right conus artery arises directly from the anterior aortic sinus, it is called third coronary artery. Okay, these are asked in Viva and MCQs. Annulus of Venous, it is an anastomotic necklace formed around the infundibulum, that is outflow tract of right ventricle, also called Venous isthmus or Venous limbus or Venous ring. Okay, named after French anatomist Raymond Venous, formed by right conus artery, that is branch from right coronary artery, and left conus artery branch from left circumflex coronary artery. Okay, so this is how annulus of Venous is formed. Next we go to synodal artery. In 65% individual arises from right coronary artery, whereas 35% cases from left circumflex coronary artery. Right and left coronary arteries give rise to vasa vasorum to the ascending aorta. Next we go to the branches of the left coronary artery. It's divided into two branches, two main branches, anterior interventricular artery and this is circumflex artery. Okay, and from this other branches are arising. So, the left coronary artery arises from the left posterior aortic sinus of ascending aorta, and left coronary artery is larger than the right coronary artery. Main trunk of the artery divides into anterior interventricular artery and left circumflex coronary artery. The main trunk, left coronary, next we are discussing the course of the left coronary artery. So the main trunk, the left coronary artery passes to the left between the pulmonary trunk and left auricle, ends by dividing into anterior interventricular and left circumflex coronary arteries. Next we discuss these two branches. Anterior interventricular artery descends along the anterior interventricular groove here. Anterior interventricular artery descends along the anterior interventricular groove and it runs around the inferior heart border here and enter the posterior interventricular groove where it ends by anastomosing with posterior interventricular artery. Here is the anastomosis. Okay. So, this is important. This is asked in your viva where the anastomosis is occurring in the anterior interventricular groove or posterior interventricular groove. Next is left circumflex coronary artery. It runs in the left part of the atrioventricular groove, winds around the left heart border to reach the posterior part of the atrioventricular groove and ends by anastomosing with the right coronary artery near the crux of the heart. Okay, crux of the heart, you know crux of the heart? Yes or no? You have been shown in your heart viscera? You don't know. Crux is the junction between the posterior atrioventricular groove, posterior interarterial groove and posterior interventricular groove. All these grooves are meeting posteriorly. That point is known as the crux of the heart. Okay. So, near the crux, it ends by anastomosing with the right coronary artery, the circumflex coronary artery. Here the anastomosis is occurring. Next we will discuss the branches of these arteries. So, anterior interventricular artery or left anterior descending. You have seen this coronary, this term LAD, left anterior descending in the coronary angiogram plates. These terms are used. Okay. So, left anterior descending artery, it gives these branches. Anterior ventricular branches that supply the sternocostal surface of right and left ventricle. Diagonal artery, it is the largest anterior ventricular artery. Occasionally, it arises from the junction of anterior interventricular artery and left circumflex coronary artery. Left conus artery supplies the pulmonary conus. Okay. Next we go to the branches of left circumflex coronary artery. It gives these branches ventricular branches to supply the sternocostal left and inferior surfaces of left ventricle, atrial branches to supply adjacent area of left atrium. SA nodal artery, sinoatrial nodal artery arises from left circumflex coronary artery in 40% of individuals, and left marginal artery, it runs along the left heart border towards the apex. Here is the left marginal artery going towards the apex of the heart. This part is apex, base is lying posteriorly. Next is posterior interventricular artery. Left circumflex coronary artery continues as posterior interventricular artery in only 10 to 20% of individuals. Okay. Next is Kugel's artery. It is the arterial branch of left coronary artery that anastomoses with similar branch of right coronary artery along the anterior wall of the atrium. So, these are the branch of left circumflex coronary artery. So, what is area of distribution? Left coronary artery supplies these following areas of heart: left atrium, left ventricle except the area adjoining posterior interventricular groove, right ventricle adjoining anterior interventricular groove, interventricular septum, anterior two-third, only anterior two-third, and left bundle branch of bundle of His. So, all these are supplied by left coronary artery. So this is the summarization of left coronary artery. Arises from left posterior aortic sinus of ascending aorta. So it has a short trunk, divides into two branches, anterior interventricular artery and left circumflex artery. Anterior interventricular artery runs in the anterior interventricular groove, and these are the branches: anterior ventricular branch, diagonal artery, left conus artery, septal branches. And left circumflex artery runs in the left AV groove, and these are the branches: ventricular branch, arterial branch, atrial branches. Some of the atrial branch is known as Kugel's branch. Synodal artery in 35% case, left marginal artery and posterior interventricular artery in 10 to 20% of cases. So these are the branch of left circumflex artery. So this is summarization of left coronary artery. Now this is asked in your viva, very important: blood supply of the interventricular septum. So from anterior and posterior interventricular branches, it is getting its supply. Anterior 2/3 of the septum is supplied by anterior interventricular branch, which comes from left coronary, and posterior inferior 1/3 by the posterior interventricular branch, which is coming from the right coronary artery. Okay. So you practice a schematic diagram like this. Next we go to coronary dominance. This is very frequently asked clinical aspect. Okay, what is coronary? Explain why question, or in long question, part of the long question it can come, or asked in your viva during viscera. What is coronary dominance? Coronary dominance is also called coronary predominance. Coronary dominance is based on origin of posterior interventricular artery. This point is important. It is based on origin of posterior interventricular artery. Types of coronary dominance: two types, three types mainly. Okay, right, left and balanced. Right coronary dominance, if the posterior interventricular artery arises from right coronary artery, it is called right coronary dominance. About 90% individuals have right coronary dominance. Left coronary dominance, if the posterior interventricular artery arises from left circumflex coronary artery, it is called left coronary dominance. Only 10% individuals have left coronary dominance. Next is balanced cardiac dominance. It is rare condition where the posterior interventricular artery is derived from the junction of right and left circumflex coronary artery. Okay. So balanced cardiac dominance is very rare situation. Only these two are present. 90%, 10%. Okay. Anastomosis of coronary artery is anatomical and not physiological. Hence, sudden occlusion of coronary blood supply results in myocardial infarction. That explains why question I told you. Coronary arteries are coronary anastomosis increases with advancing age of an individual, and hence the myocardial infarctions are more fatal in young individuals than in the old one. Okay, because with age anastomosis increases. So there is high chance of perfusion through this anastomoting part. And coronary vessels also anastomose with branches of internal thoracic arteries, bronchial arteries, pericardiacophrenic arteries and esophageal arteries. That means nearby arteries. They can also anastomose with them. Okay, so this is the location of pain in angina pectoris. Okay, angina pectoris means ischemia due to blockage in the coronary arteries. It extends in the left part of the chest, extends to the medial side of the arm, forearm, and it can extend up to the finger, and also extends to the left part of the neck and left shoulder. Okay, this is the extent of pain in blockage of the coronary artery, angina pectoris. Okay. and it mainly occurs due to coronary atherosclerosis. This is normal vessel, and here the plaque has been developed. Plaque is formed by cholesterol, macrophages, calcium deposit, and so on, and it will gradually narrow the lumen, and there will be obstruction to the blood flow. Okay, coronary artery atherosclerosis is very common. So angina pectoris, it is a referred pain from the heart, and that is felt in the chest region because of reduced blood supply to the heart. Coronary atherosclerosis is the deposition of lipids in the tunica intima of the coronary vessels. That is inner layer of the coronary vessels. What is ischemic heart disease? It comes as a long question, okay, part of long question. This comes actually together. Coronary describe the coronary circulation, and another part will be this ischemic heart disease. So ischemic heart disease is also called coronary artery disease. What is the definition? Ischemic heart disease is a condition in which myocardium does not receive adequate supply of blood and oxygen. What are the causes? Coronary atherosclerosis is the major cause of ischemic heart disease. Or this is the classification of ischemic heart disease. Ischemic heart diseases are classified based on the severity of the disease. Angina pectoris, this is stable and unstable angina. Okay, and this is the low grade heart attack. Then there is myocardial infarction. In large part they are losing their blood supply in myocardial infarction. Then there will be heart failure. The movement of the heart valve will be lost because of loss of blood supply. So there will be heart failures. Then there will be development of arrhythmias. Okay, conduction system is not functioning properly due to loss of blood supply. So there will be arrhythmia, and then there will be sudden cardiac death. Okay, patient will die. Heart will stop working, patient will die. Okay, so this is in increasing severity. First there will be pain. Pain is continuous pain, is stable angina. There is pain coming and going, that is unstable angina. That is occurring due to ischemia, temporary loss of blood supply. And due to temporary loss, there will be angina pectoris. If there is permanent loss of blood supply, it will lead to myocardial infarction. Then if due to loss of blood supply, heart will lost function, some part of the valve will lost function, that will lead to heart failure. And due to loss of blood supply to the conductive system, the rhythm of the heart is lost, that is known as arrhythmia. Okay, and then there will be death of the patient due to loss of heart function, that is sudden cardiac death. Okay, see here, this is the blockage areas. Here left anterior descending artery block, anterior interventricular artery is blocked. In 40 to 50% cases this occurs, and right coronary artery block, 30 to 40% cases it occurs, and 15 to 20% cases left circumflex coronary artery block occurs. Common sites of coronary occlusions. And other common sites include the left coronary artery main trunk and inferior posterior interventricular artery. Okay. So we will discuss this grading of ischemic heart disease. First, angina pectoris. It is pain which occurs in the chest due to reduced blood or oxygen supply to the heart. Angina is paroxysmal and usually recurrent attacks of substernal or precordial chest discomfort. It is caused by transient myocardial ischemia, that is insufficient to induce necrosis of cardiac myocytes. Okay, loss of blood supply is very for less time, 15 seconds to 15 minutes. It is described as heavy, tight or gripping pain that is typically retrosternal. Okay, heaviness in the chest. Patient will complain as heaviness in the chest. It is also referred to the left shoulder, medial side of arm and forearm. Angina pectoris may be stable and unstable. Stable angina, type of angina that begins on exercise or physical activity. Okay, unstable angina occurs at rest and lasts for more than 20 minutes. It is severe than the stable angina. So in unstable angina, severity is more. Okay, stable angina, normally patient is normal, but if patient exercises or having some physical activity, then pain comes. Okay. Next we go to myocardial infarction. A sudden occlusion or branch of coronary artery lead to complete loss of blood supply of the specific area of the heart. At this area, myocardium undergoes infarction, that is reduced blood supply, and finally leading to necrosis, that is tissue death. Infarction means there will be tissue death. An infarction produces the following symptoms: angina pectoris that last longer than 30 minutes. Okay, in angina it was almost 20 minutes or nearby to it. Unstable angina, there it lasts about 20 minutes. Stable angina 15 minutes. And there will be nausea and vomiting, shortness of breath, sweating. Commonly involved vessels in coronary occlusion are anterior interventricular artery. We have seen on this previous picture in 40 to 50% of cases, that is left anterior descending, LAD. Right coronary artery in 30 to 40% cases, and left circumflex coronary artery in 15 to 20% cases. Here ECG is being done. This is the most commonly advised investigation in heart block. Next we go to cardiac arrest. It is a sudden loss of blood flow to the body due to failure of pumping function of the heart. Myocardial infarction is most common cause of cardiac arrest. If cardiac arrest is not treated within minutes, it leads to death. Okay. The signs of cardiac arrest are loss of consciousness, abnormal or absent breathing, severe chest pain, vomiting, and so on. You have to give CPR, cardiopulmonary resuscitation, okay, if cardiac arrest occurs. So these are the investigations we do. ECG, electrocardiography. It is a method of recording a graph that represents the myocardial activity. ECG we learn in details in physiology. So ECG shows P, Q, RS and T waves and on ECG, ST segment is elevated in myocardial infarction. This point is very important. ECG also you will get in your final year medicine. There are many other changes observed based on involvement of specific part of the heart. Next investigation is echocardiography. It is method of examination of heart using ultrasonic waves. Okay, it is done with ultrasonic probes. Uses is to assess the thickness, size, shape, movement of heart chambers. Next is Doppler echocardiography, used method to record the blood flow through the heart chambers and measure vessels. Doppler means you are seeing the blood flow through the vessels and the heart chambers. It is useful for detection of valvular functions. In case of incompetency of the valve, blood can flow in opposite direction. Okay, so you can detect through Doppler echocardiography the valvular incompetency. So it is useful for detection of valvular functions and septal defects. ECG being done, this is the leads are placed over the chest and this is the graph P, Q, QRS complex and then T. Okay. This is echocardiogram. This is the chambers of the heart has been shown. Left ventricle, left atrium, right ventricle. Okay. Here is the echocardiography probe is placed here to see the heart. Next we go to the coronary angiography and angioplasty, very frequently done in so you have to place the catheter through the femoral artery. Femoral artery is continuation of external iliac artery, then pass through the external iliac artery, then common iliac, then through the ascending abdominal aorta, through the thoracic aorta, arch of aorta, enter into the right through the aorta. The catheter is pushed through here and the dye is pushed into this arteries. Okay, catheter in the aortic sinus, and it will push the dye through the coronary arteries, through the opening of the coronary arteries to visualize the arteries, and if there will be blockage, you cannot see the rest of the portion of the artery. So this is the route of the catheter. So coronary angiography, it is a radiological procedure to visualize the coronary arteries. A long catheter is inserted through the femoral artery in the inguinal region, and then it is directed to the ascending aorta. Femoral artery, external iliac artery, common iliac, descending abdominal aorta, descending thoracic aorta, arch of aorta, ascending aorta. A radio-opaque dye is injected into the coronary artery and radiograph is obtained, and this coronary angiogram shows branching pattern of vessels and site of block. Okay. See, this is the normal coronary angiogram. Here is the right coronary artery and its branching has been shown. Okay, this is the opening conus artery, and 2 is the acynodal artery, 3 is right marginal artery, 4 is posterior interventricular artery, 5 is posterior lateral ventricular branch. And this is normal left coronary artery angiogram. 1 is anterior interventricular branch here. Okay, and 2 is diagonal branches. Here is the diagonal branches. 3 is circumflex branch and 4 is left marginal branch. So this is how the angiogram looks like. Anterior interventricular artery. Here is the right coronary artery, posterior interventricular artery. If there is blockage, rest of the portion you will not see. Left coronary artery angiogram. Okay. Here is anterior interventricular branch. 2 is the septal branches. 3 is circumflex branch. 4 is left marginal branch. Next, how will you treat? This is a coronary angiogram. If you see there is blockage, then what you will do? You have to do coronary angioplasty to treat the patient. So this is how angioplasty is done. A catheter is pushed with a balloon in situ, and there is a stent which is expanded through the expansion of the balloon, and the mace is kept here. Stent is made of this mace. Stent is kept here, and the balloon is deflated, and you can see the blockage is removed through this stenting process. This is known as coronary artery angioplasty, and blood flow is recovered. So coronary angioplasty is procedure used to open the blocked coronary arteries. Okay, these are very frequently coming clinical aspect. Part of long question it can come or as a short note. Procedure: a catheter with inflatable balloon and stent, that is wired mesh tube, is inserted into the coronary artery through the femoral artery, and at the site of block, balloon is inflated. Later, the balloon is deflated and catheter is removed, leaving behind the stretched stent, and this open up the lumen of the blocked vessel, and it is performed by cardiologist. Next is you can do coronary artery bypass graft. If stenting is not possible, their blockage is larger, then you can do coronary artery bypass graft. It is done by cardiothoracic surgeons. So it is a surgical procedure used to bypass the blocked segment of the coronary artery. What is the procedure? A segment of vessel is connected to the ascending aorta or proximal part of coronary artery, and the part of coronary artery distal to the blockage side. Vessels used for bypassing graft is internal thoracic artery, great saphenous veins, and radial artery. Okay, here is internal thoracic artery has been used. Okay, internal thoracic artery is branched from subclavian artery. Internal thoracic artery is mobilized from the chest wall, and it is connected to the coronary artery distal to the blockage. Here is the blockage, here the artery is connected. So blood will come from internal thoracic artery and supply the coronary artery branches. Here left coronary internal thoracic artery is connected distal to the blockage. Okay, like this it is used, and this great saphenous vein some part of the vein is removed from your leg and it will connect proximal and distal part of the block area. That's how it is done, angioplasty. Coronary artery bypass grafting. Here the internal thoracic artery, coronary artery bypass grafting using internal thoracic artery. Right internal thoracic, left internal thoracic. You have seen in the chest wall internal thoracic artery. Next we go to the veins. Veins are very important. Main venous part is the coronary sinus. All the veins draining the heart is draining into the coronary sinus. Anterior cardiac vein and venicordi minimi directly draining into right atrium. This is right marginal vein, small cardiac vein, middle cardiac vein. This is great cardiac vein, left marginal vein or oblique vein of left atrium. All these are draining into this coronary sinus. And here is the opening of coronary sinus into the right atrium. Okay. This is the position of coronary sinus. All the veins are going to drain here. So venous drainage of heart, venous blood of heart is drained by these following veins: coronary sinus, anterior cardiac veins, venicortis minimi. About 60% of venous blood from the heart enters into the right atrium, whereas remaining 40% enters into different chambers of the heart. It is the major vein of the heart, coronary sinus. Size is about 2 to 3 centimeter long. What is the location? It is located in the posterior part of the atrioventricular groove. What is the development? Develops from the left horn of the sinus venosus and a part of left common cardinal vein. It begins as continuation of great cardiac vein in the left part of the AV groove. How it terminates? Coronary sinus opens in the right atrium. Opening lies in between the opening of inferior vena cava and right atrioventricular orifice. Opening of coronary sinus is guarded by non-functioning rudimentary Thebesian valve. Name of the valve asked in your Viva and MCQ. This is the coronary sinus. You practice a diagram. Coronary sinus individually can come as a short note. Coronary sinus. What are the tributaries of coronary sinus? It receives following tributaries. Great cardiac vein begins at the apex of the heart. See, this is the great cardiac vein lying in the anterior interventricular groove along with the arterial. It begins at the apex of the heart, runs upward in the anterior interventricular groove, then runs in the left part of AV groove, turns around the left heart border, opens in coronary sinus. This is blood from left marginal vein. Middle cardiac vein begins at the apex of heart, runs in the posterior interventricular groove, opens in the right end of coronary sinus. Small cardiac vein lies in the right part of AV groove, opens in the right end of coronary sinus, receives blood from right marginal vein. Okay. Posterior vein of left ventricle drains the diaphragmatic surface of the left ventricle, opens in the coronary sinus just left to the middle cardiac vein. Here is small cardiac vein, here is middle cardiac vein, this is great cardiac vein. And this is inferior vein of left ventricle, also known as posterior vein of left ventricle, because it is lying posteriorly or inferior surface, that's why inferior vein. Oblique vein of left atrium, this is oblique vein of left atrium. Small vein drains the posterior surface of left atrium, opens into left end of coronary sinus, remnant of left common cardinal vein or duct of Cuvier. Right marginal vein, it runs along the inferior heart border, opens into the small cardiac vein. This is right marginal vein. Sometimes opens directly into the right atrium. Left marginal vein runs along the left heart border, drains into coronary sinus. Here is the left marginal vein. So this is summarization of venous drainage of heart. It drained by anterior cardiac veins, opens directly into right atrium, coronary sinus, and venicortis minimi opens in all the 4 chambers of the heart. Coronary sinus is main vein of heart, lies in AV groove, termination opens into right atrium. These are the tributaries: great cardiac vein, small cardiac vein, middle cardiac vein, posterior vein of left ventricle, oblique vein of left atrium, left marginal vein, right marginal vein, opens in small cardiac vein. Anterior cardiac veins, this is cutting open of the right atrium. Okay, these are
Small anterior cardiac veins are 3 to 4 in number. These are small veins that drain the infundibulum of the right ventricle, open directly into the right atrium. And these are the opening of veni cordis minimi, also known as Thibesian vein, where multiple small veins are present. These are small veins that opens into the all the 4 chambers of the heart through the foramina minimarum. Okay, this is foramina venerum minimarum. Okay, that's all. Any queries regarding today's topic? So prepare it, very important question. Coronary circulation, prepare as a long question, or coronary arteries individually come as a short note. Coronary dominance is very important for your Viva and MCQ. And this venous drainage, coronary sinus, prepare as a short note. Okay, ischemic heart disease is also an important question. Okay, understood? That's all. Thank you.